So firstly, I would just very briefly like to welcome you to the very first session of NTW 22. This conference is the most extensive yet for Thrombosis UK, and I'd like to thank all of the supporters, the professional bodies and sponsoring organisations who have helped make this possible. Many have stands in the exhibition area, and I urge you to visit and benefit from the resources and materials available. The next 2 weeks provide a wealth of learning and update across evidence, prevention, management, guideline recommendation, and much, much more, including the challenges of implementing VTE best practice. And this morning, as CEO of Thrombosis UK, I feel honoured that we're opening this conference with two people who are passionate about making a difference in VTE and to patient safety, Dr. Aidan Fowler and Professor Roopen Arya. We really want your involvement too in this session, so please do use the Q&A button to share questions and comments for Aidan and Roopen. Now, for those of you who have not met Roopen, I'd like to introduce him. He is Professor of Thrombosis and Hemostasis at King's College London and Director of the King's Thrombosis Centre and Lead for Thrombosis and Hemostasis at King's College Hospital. He's the clinical lead for the National VTE Prevention Programme at NHS England, and as Director of the National VTE Exemplar Centres Network, has overseen the establishment of more than 35 VTE Exemplar Centres, an amazing achievement. Roopen has research interests in venous thromboembolism, anticoagulation, thrombophilia in women's health, and the use of global coagulation assays to define bleeding and prothrombotic states. He's also very active as lead clinician and deputy clinical director at King's College Hospital and across the Southern Haemophilia Network. So without any further delay from me, I'd like to pass to the chair of this session, Professor Roopen Arya. Thank you.
Thank you, Jo, for your kind words. Welcome, everyone, to National Thrombosis Week 2022. In fact, there's so much to highlight and discuss that this week stretches over 2 weeks. So thanks to Thrombosis UK, as ever, for the kind of splendid efforts in raising awareness about venous thromboembolism and in promoting good practice in VTE prevention and care. This inaugural session is entitled NHS Patient Safety, using data to inform and improve VTE prevention. So it's nearly 2 decades now since the Agency for Healthcare Research and Quality named VTE prevention the #1 patient safety intervention when it comes to efficacy, safety, as well as cost effectiveness. And in 2007, it became a major patient safety priority in the NHS. The National VTE Prevention Programme was launched in 2010. And for the first time anywhere in the world, there is a system-wide approach to VTE prevention. I think central to the success, apart from the champions who have made it happen, has been our ability to monitor risk assessment rates as well as VTE outcomes, whether it's in the form of looking at the cases of hospital-associated thrombosis or the National Outcome Framework Indicator, about which we'll hear more in a moment. And more recently, the GIRF National Thrombosis Survey report was published last autumn on World Thrombosis Day, which highlighted the continuing challenges of reducing morbidity and mortality due to hospital-associated thrombosis. It is a great pleasure indeed to welcome as our keynote speaker today, Dr. Aidan Fowler, who is the National Director of Patient Safety in England and a Deputy CMO in the Department of Health and Social Care. He is a consultant colorectal surgeon, and he joined the NHS Leadership Academy and subsequently worked in mental health and community care before moving into this very, very important area of patient safety. He was also Director of NHS Quality Improvement and Patient Safety and Director of the very, very important 1,000 Lives Improvement Service for NHS Wales. So with no further ado, I'm going to hand over to Dr. Aidan Fowler, National Director of Patient Safety, to talk about using data to inform and improve VTE prevention. Over to you, Aidan.
Thank you very much, Roopen, and thank you, Jo. And We've been having a lot of fun with sharing today, but I'm going to try something slightly different. I'm taking advice on this, that I'm going to share my entire screen, and I'm going to share PowerPoint, and I'm going to put it into slideshow, and I'm going to hope that somebody says, aha, now we can see full slides. Does that works for you? Are you seeing it as you should now with a full slide?
Yes.
Excellent. So we've made progress technically, and apologies to you all for the delay in start today. So having overcome those challenges, what I want to do is throw out what I hope will be some thought-provoking information about where we've got to with venous thromboembolism prevention. And some of you will remember a while back that I spoke to you and said that this was something we considered so important that we were going to make it a priority for a new patient safety committee that we had constructed around all arm's length bodies across the NHS to try and work better together on issues of importance for patient safety. And we felt VTE was one that needed a refocus and that we could all make some form of contribution to. And so the reason for that is because we have data that says VTE remains an issue for us. And what I've put here, many of you will recognize, is a thing called Burkhoff's triad. So why do we get these thromboses? It's a combination of things. So the blood is hypercoagulable, there is stasis, there is potentially vessel wall injury. And it's important when we're talking about this to consider these, because I think part of the issue is we don't have the basic science in the back of our mind when we're doing the work. And so we do things that we shouldn't around risk assessing patients. I will come on to more of that in the future. So, slightly complicated slide, but broadly, we have a National Patient Safety Committee that has chosen to target again hospital-associated VTE deaths because it's a significant patient safety issue in terms of years of life lost as well as numbers of lives lost. It's increased as a problem relating to COVID. And we think that it requires the advantages of the Patient Safety Committee in being a system-based collaborative approach to thinking about how we target it. And you see some of the press releases we see around this continuing problem. And here's the data. And Roopen mentioned the GIRF report, and the GIRF report talks about a reduction. Now, we can look at data in a number of ways, clearly, and you will see on this graph the overall number of VTE deaths, i.e. certificates of death certificates showing VTE as a cause of death. Over time, you can see where we introduced the risk assessment, you can see where COVID began. And broadly, what you've got is a relatively flat line around the 12,000 mark until COVID hits, when it goes up to nearly 16,000 deaths, because we know that COVID was associated with thrombosis. If you looked from year 2010-11 to 2011-12, you might argue that there had been a fall, and you could publish data reasonably showing that after the risk assessment was introduced, there was a fall. You could also argue that our expectation would be that because the number of people requiring healthcare, the population who are at risk of VTE is increasing because it particularly affects the elderly, that we would have expected this line to go up over time. And so indeed holding it flat might be considered significant. What we also see is two other lines. And the one I want you to look at is the grey dotted line. That is the number of deaths, roughly 4,000 or just above, that we think are associated with hospital admissions. So people who came into hospital without a diagnosis of VTE and who died of a VTE following discharge. So these are the group we've traditionally considered amenable to our interventions. These are the ones we are trying to prevent. And as you can see, it's a pretty straight line again. What's also notable, of course, is the gap between that grey line and the light blue line, which means there are 8,000 deaths not associated with hospital that we don't really understand terribly well. So let's have a little look at the hospital-acquired group and see who we think it's affecting. So not entirely surprisingly, the number of older people affected by this is much higher. The number of people going into hospital in this age group is higher, but this profile does not match the age distribution of hospital admissions. It's also notable that there are a significant number of people who are in the younger groups. Yes, they're smaller, but you've still got a quarter of this group overall, so that's about 1,000 deaths in the under 70s group. We can also look at admission type, and what you will see here is a very significant percentage that are emergency admissions. So we have done a lot of work on VTE prophylaxis around elective surgery, clearly, and to some extent we appear to have been successful in that. But a couple of things to note, therefore. One, we have a significant number of people whose admission was an emergency admission who subsequently die of a VTE. And if you look at the overall group, actually there are quite a lot of day cases who aren't necessarily the groups you would traditionally think of as at risk. So two important points in there already. Now we can start trying to look at what specialty these people are admitted under. This is the 4,000 group again, and what the primary diagnosis was. And what you will see is there is a clear lead specialty here, which is these people are being admitted under general internal medicine, so under physicians with medical issues, and elderly care comes second. So again, a medical specialty, and only then do you see trauma and orthopedics and general surgery and emergency medicine and so on. So once you start including respiratory medicine, etc., gastroenterology is down there, you get a very significant number of admissions that are medical admissions. So what diagnosis do we see in these? And there is a caveat around this. So if you look at primary diagnosis here, it's important to look at the numbers on the graph. There is no one condition here which goes above 10%. So there's nothing that's a majority of cases, but if you add up all the infection-related issues, they're about a quarter of the problem. And you can see in the lead there, influenza and pneumonia, so respiratory infections. Now, of course, respiratory infections are one of the most common types, but they seem to predominate over the other common one, for example, which is urinary. So something about medical admissions, respiratory infections, and infections in general, which is potentially leaving people at risk. What we don't know is other underlying conditions. So I can't tell you of those admissions with influenza and pneumonia whether any of them had an underlying lung cancer, for example. So the data come with some caveats at this point. What we have here is the current VTE risk assessment tool. So NICE provides their guidelines in 2018. The risk assessment tool, you can just see at the bottom, if you look very closely, was copyright 2010. So relatively old. It's a Department of Health thing. Department of Health would not be writing these guidelines now. Now, as somebody who hasn't used this for some time, reading through it was interesting with the perspective of someone concerned about safety. And I would ask the question, is this a risk assessment tool? So if we look at the top, it says, are you a surgical patient? Are you a medical patient expected to have ongoing reduced mobility relative to normal state? And are you a medical patient not expected to have significant reduced mobility relative to normal state? So it is very easy, therefore, to come to the conclusion that your medical patient is not expected to have reduced mobility, therefore is not at risk if the risk assessment is ticked in that box and the risk assessment is now complete. Back to good old Virchow's triad. Stasis is only one element of the triad. And the other one is hypercoagulability, which includes blood being affected by inflammatory markers and so on. So it is possible to make the argument that medical patients with infective conditions who might be dehydrated, who might have inflammatory markers affecting their risk of blood clotting, maybe are not best served by this risk assessment. If you look at some of the other elements to it, it's either something that you will be driven to tick through as quickly as possible because you are a busy person trying to get through this, or it's something that if you look at all the information required, you could arguably spend your whole day trying to answer the questions properly and obtain the information you need to fill in this accurately. So I would be making the argument that we might want to look at this again and think about whether this is the right tool, because what I suspect it does is give you too much leaning towards defaulting away from prophylaxis rather than towards prophylaxis, which is what we might want to see. So what should we do about all this, having introduced where we are concerned? So I think there is an argument for thinking about how we relook at targeting hospital-acquired VTE. I would argue that we should be relooking at the VTE risk assessment tool. There is a lot we do not know about the potential benefits of using oral anticoagulation and or dosing of heparin, for example. So we've been using heparin for a long time. The dose was essentially based on pretty standard average patient weights for the time. Those have now changed. It was based on trying to give a dose that would have impact and not cause bleeding. I think it's time for review of approach and dosing, and we might want to consider greater use of oral anticoagulation, and we might want to think about dosing, especially since we know that obesity is a greater problem. We are probably underdosing some of our patients and therefore leaving them at risk. I think there is an argument for looking at potentially amenable groups to target, such as those admitted to medical wards with infection. But I would also be very interested in those treated, and my GP colleagues tell me that we treat people much more in the community than we used to. If you have a respiratory infection in the community, are you just as at risk as you would be if you were admitted to a hospital? And could that be part of the 8,000 that we poorly understand who are dying not related to their hospital admission? So I think there is a lot to be gained about understanding that 8,000 and understanding how we reduce risk in these medical groups. And particularly when you think about current programs such as the virtual ward, if we're going to be treating more people out of hospital, which feels like the right thing to be doing, we have to think carefully about how we address VTE risk in the community. We also need to look at the overuse of anti-embolism stockings. They've been around for a very long time. Those of us who've spent time in hospitals will have seen them acting as a white tourniquet, where they are not fitting correctly and they're digging in just below the knees and probably causing greater risk. And there isn't good evidence for their use, and yet they're still pretty dominant, as well as thinking about other devices such as pumps and the benefits of those. So quite a lot, I think, of areas for potential research into who is currently in hospital, who's predisposed to VTE, what are the treatments that we can give to reduce the risk, how do we dose those, do we give oral, do we give subcutaneous heparin, etc. I think also importantly, we have the 2/3 of this group of deaths in the 8,000 that we don't really know what's out there. So it could be people taking the oral contraceptive pill, flying, getting infections. We need to understand better what makes up that group and how many of them are healthcare associated in the broader sense, i.e. potentially amenable because they are interacting with healthcare at some level, and therefore there might be a trigger point at which we could say, you have pneumonia, we're going to give you antibiotics, we're going to treat you in the community, we're going to monitor you in the community, we have oximetry, we have other mechanisms for remote monitoring now, but we also recognize that even if you are actively mobile, you are more at risk, and therefore we should be thinking about your VTE risk and treating that. And if some of that is not healthcare associated, are there opportunities for public education around what leaves you at risk of a VTE? Because 12,000, and now with COVID around, higher than that, deaths a year is a very big number. We also have been thinking about how we collaborate across organisations through our National Patient Safety Committee, and it's been really heartening how much people have come forward, whether that's estates, public health, etc., with opportunities they believe they can take to help with this condition. So that's pretty much what I wanted to say today, and I'm open to challenge, questions and comments on all of that. Roopen, I will hand back to you for now. Thank you all for listening.
Thanks, Aidan. That was very, very valuable work, some of which, confirms the existing epidemiology and suspicions. I think we have to celebrate, what has been done in the NHS in the past 10, 15 years, because I think it has been a big achievement, putting systems in place. And that death data you presented at the outset, was quite interesting, that it looked flat, but if you look at the National Outcome Framework Indicator, which includes a denominator for the number of admissions, which has gone up about 25% during that time, I think we have seen a fall by about 16% over the years since we have been doing kind of formalized risk assessment. And clearly, that framework indicator has gone up in the past year because of COVID. Unfortunately, thrombosis is a very significant complication of COVID, this phenomenon of immunothrombosis. And particularly after the first wave, we saw 3 times as much pulmonary embolism as we usually see during that time. But I think it's very, very valuable to be able to share that data. And I'm really grateful that the team at NHS Patient Safety, are analyzing the deaths data, particularly, that 4,000, I think is, again, a similar number to what is in the outcome framework indicator, where VTE is in the first 3 positions in the death certificate, but there's always been the 8,000 or 9,000. And I really welcome, I think, the plans, if there are plans, to try and look at those deaths as well, because there's many, many unanswered questions, particularly around the community acquired VTE and what happens in nursing homes. And clearly this hospital at home or the virtual ward, I think has been a very new model. And also, I think there's a lot of confusion around what to do in mental health institutions, because some of the guidance, including from NICE, has been to risk assess these patients, but there's absolutely no evidence in existing studies for the extent of risk in mental health or what would constitute appropriate prophylaxis in that group of patients. So I think there's a lot of unanswered questions, and really what I heard, is very, very welcome, that is being taken seriously and further work is being done. So the Healthcare Safety Investigation Branch, is that, again, part of patient safety? I see there have been some recent investigations on, for example, pulmonary embolism after stroke, or on diagnosis of PE in emergency departments. Is that also part of your initiative?
So just to make a few comments. I hope what people heard me say was that my expectation would have been, if we'd done nothing, that the number would have gone up. So a flat line, as you say, with more admissions means we are achieving something. I hope people also heard me say that I thought that it was notable that the predominant groups were not elective surgery, where I think we have been very focused on VTE prevention. And I think what I was trying to say, whilst accepting I was sort of provoking thought, was there's optimism here because there are amenable groups still, and there's more to do and more we believe we can do. So I think I'm coming from a perspective of optimism that we can do more in this space. And as somebody who's taken an interest in improvement, what you see with improvement initiatives is they achieve things, they tend then to plateau, and you need to go back at them and say, right, what more can we do? What perspective can we take? In answer to your question about HSIP, HSIP is part of the patient safety landscape. It's currently an organisation undergoing a significant amount of change. With the passing of the bill, it moves to independence fully from Department of Health and NHS England and Improvement, who've been looking after it. And that gives us great opportunity to relook at how the organisation functions. They are often at our patient safety committee, but not a standing part of it for various reasons around the fact that we have a responsibility for ensuring that their recommendations are followed. So we work on that. But yes, they have done a number of pieces of work in this and are always open to investigating the sort of more complex patient safety issues of concern for people. So anyone can contact them and say, look, we have a particular area of concern, and they will look at it in depth using their strong investigatory skills and make recommendations, which we then support them to follow up and make sure that they are implemented. So yeah, they're very much part of the safety landscape.
And looking at your updated patient safety strategy as well from last year, I think medication safety is a large part of this, from what I understand, and certainly, you know, a couple of things that triangulate, I think, with the curved thrombosis survey was, you know, the prominence, for example, in those who had inadequate thromboprophylaxis, you know, of omitted doses of thromboprophylaxis, and also people not necessarily giving weight-based dosing as they ought to. And again, it was of interest to me that you specifically did highlight that. And again, I think, you know, it probably all triangulates very nicely, you know, including, you know, I think the increasing role of the medical examiners looking at, you know, the deaths in healthcare, and again, picking up the VTE related deaths, isn't it? So
yes, and we see a significant rate of people who do not get the dose that they were supposed to get administered. That continues to be of concern, and medication safety will remain a priority for us. It's a priority for the WHO, as you may know. It's definitely a priority for us. I think what we want to do around medication safety is remove a little bit of some of the complexity. So there are a whole series of medical optimization programs sitting in another part of the camp. We just want to make sure that medication safety is embedded fully in all the medication programs, and that we work as a sort of coherent part of medicines optimization overall. But we will continue to focus on medication safety, and particularly around this area.
I'm trying also to include some of the questions in the Q&A, but may I also ask, because it's something that is very close to my heart and that of Joe's as well, is, you know, of the work around education of hospital-associated VTE, you know, as part of the patient safety curriculum. Because I'm sure you're aware that nearly 10 years ago now, we created these modules with Health Education England that are part of mandatory training in the trust. But are there plans to try and further drive education around HATs?
So I think, I mean, we have a patient safety syllabus now, which is more about generic safety thinking rather than specific issues. There's training around that, and we're revising it all the time, and we're working with HE on that. And I think the question in the future is, how much of that training is generic and how much of it then is specific around particular issues, and how much we use that platform for training on specific issues. There is always a concern that training as a barrier to safety issues is not strong on the sort of hierarchy. And so we're always looking for ways where we can create systems that drive people to do the right things. So for example, using electronic systems that prompt you to do what you need to do around VTE prophylaxis, rather than relying on people remembering their training and education and remembering to think about it, making it, if you like, impossible to go through a patient's pathway without addressing the risk assessment, subject of discussion, and treatment, and not relying on people's memory and training and education where possible.
Yeah, thank you for that. I mean, clearly, you know, VTE prevention is much better embedded in business as usual at the trust. But, you know, as we find out from the continuing cases of hospital-associated thrombosis, despite everything that we do, that, I mean, there's a continuing need to highlight that. Again, I did have a look through your latest patient safety strategy, and there's quite a lot of emphasis on patient involvement as well, isn't it, and patient awareness. And I'm sure to Joe, as the CEO of Thrombosis UK, that is something that would be of particular interest to her. And I remember from various meetings at the Department of Health in the early stages of the VTE prevention program, you know, that there was a lot of our work that was driven by questions from families, including bereaved families. You know. So do you want to comment on patient involvement?
I agree, Roopen, and I think also what Gurf showed was we're still being challenged by access to information throughout the journey, but even just on diagnosis and discharge. And I think if there's any way we can work all together to improve this NTW, we've certainly circulated over 100,000 printed materials to hospitals around VTE prevention, specifically to give to patients being admitted. But if there's more we can do, because that is where we hear over and over again from families and from individuals that they weren't aware, and there has been a break somewhere in that journey, however unintended it was, to miss the opportunity to share information, discuss, and for that individual to leave feeling reassured and understanding what next. And when they don't do that, not only can physical complications occur through the dosing of treatment, through reoccurrence of events, but we see, and there's evidence, clear evidence about the psychological impact and the long-term impact this has on those individuals. So yeah, for us, and certainly, you know, for the team at Thrombosis UK, this is a really important area we would love to do more on with you and to work with.
Thank you.
Go on, Aidan, do you want to respond?
So I was just going to come back and say that by the end of this year, there will be a patient representative, well, two actually, on every quality committee in every organisation. And they will be looking out for these sorts of things and be the voice of the public on those. We're preparing material as we speak to give to patients to help empower them when they are admitted to hospital, particularly to keep themselves safe. They obviously have more skin in the game than anyone, and we need to give them the tools, particularly recognizing what we've learned about inequalities and through our own work about inequalities, making sure we give equal capability to all our patients to know what it is they can do to keep themselves safe in hospital, which will include asking about, you know, what is my VTE risk and what can I do to prevent it and what should I expect, so that, you know, if people do forget to do the right things, they can be challenged on that.
Yeah, as Joe alluded to the GIRF report, and I think it was one of the prominent findings that even 10 years on, it's something that we are not very good at doing. And yeah, so it's important that we continue with those efforts. Now I'm just picking up some of the questions from the Q&A. There's a question about what is the best risk assessment tool.
It's tempting to say the next one.
Yeah, I mean, it's a very difficult area, and with Thrombosis UK as well as ISTH, our group has specifically addressed this in whole lectures, and it's very, very difficult because even Dan Horner and Steve Goodacre looked at it as part of their NIHR sort of sponsored systematic review of risk assessments, and I think there are some risk assessments that are better validated than others, like the Caprini, for example, which is more suited to surgical patients, but that has about 79 different variables, and in its simplified form, it's got 36 variables and could not exactly be said to be user-friendly. And I think, again, we struggle with the risk assessment models, of being able to demonstrate an improvement in the outcomes. So I think it is a challenge. I don't know the answer to that question. And certainly, I think the national risk assessment model, and again, I was part of that CMO's group, and it literally was a kind of back of the napkin kind of job that we came up in one of our meetings. And unfortunately, because one tick, drives the risk of thrombosis or bleeding, we've never been able to validate it, because the house officer, after ticking one box, has lost interest in more fully documenting the risk. But my answer to that is to use the risk assessment model that works for you. I still think a risk assessment, as the trigger for thromboprophylaxis was the right thing to focus on, because it did help drive good practice. And, at that time, particularly in medical patients, the view was just to go ahead and give everyone prophylaxis, which I don't think is the right thing to do. I think we are probably, there's of the patients receiving prophylaxis, probably quite a large number who are probably receiving more prophylaxis than they need, but there's a very significant number that are probably getting less than they need, which is probably one of the reasons why now, even in the GIRFT survey, the majority of cases of hospital-associated thrombosis were due to a failure of gold standard prophylaxis. So in a subgroup of the patients, they probably need escalated prophylaxis or some other form of prophylaxis. Again, as you alluded to from the GIRFT survey, we found that there were medical patients and obstetric patients receiving anti-embolism stockings where they're not indicated and have the potential to do harm. So I think you're right. The right risk assessment model is probably the next one coming along, but and there's only one that looks at bleeding, which is a constant concern we hear about from surgical colleagues. So, but your data was very interesting in highlighting, I think, what has been highlighted in RCTs like Medinox, in that the medical patients seem to be the main group in which we are seeing hospital-associated thrombosis. Now, in part, I think probably because medical patients have lagged behind surgical patients in receiving thromboprophylaxis. And I think in part, I think the modern surgical techniques and earlier mobilization and early discharge, mean that even in the high-risk surgeries, we are not talking about the 50% venographic rates with total hip replacement, but nearer 1.5%. despite prophylaxis. So I think that landscape is changing. I mean, the day surgery data that you presented was interesting. Do you want to comment on that?
Well, again, these are early data, but it's a standout thing that you've got 7% of that group who are day surgery admissions. So the majority were emergency admissions, as you saw, but there's a group of day surgery admissions, and it's back to this assumption that people are only at risk from long periods of immobilization. I think with surgery, what we haven't always got right is the ability to, as we discharge people quicker, to make sure that they continue to get thromboprophylaxis at home. I think that's probably a weak spot. I think on the medical patients, I mean, my concern, and again, we do not have the data here to answer the question of those medical patients, if they have an infection, how many of them, when they have the risk assessment, the box is ticked saying they will be normally mobile, and they then don't receive thromboprophylaxis, and how many of them are actually receiving thromboprophylaxis. So that's the next question to answer with that group, and we will be talking to College of Physicians about their thoughts on that group of patients and their amenability. And I think, you know, to this point about risk assessment, well, one, there's a whole debate about what a risk assessment is, but also, and you mentioned bleeding. I mean, you know, we know the basic psychology is that people would rather do nothing and see a person at risk than do something and put them at risk. So that's basic psychology. And if people are concerned about a risk of bleeding, which is probably rather overemphasized, that addressed at the time of the risk assessment is a useful thing. So you need to know, well, this risk assessment of bleeding is done at the same time, and actually if they don't appear to have a risk assessment of bleeding, you can park that and go back to the fact that what we want to drive is a culture of almost a default to treatment rather than away from it. So the normal thing would be to treat people unless you've got a good reason not to, rather than any doubts, we don't, which I suspect is what currently happens, and certainly seems to be the feedback from a number of our colleagues and clinicians. So yeah, there is much more. And somebody says, is there room for research here? Absolutely there is. There's so much more that we could understand that I think merits further assessment. And it's that there is more opportunity here. So let's see how best to take that.
Yeah, I mean, there is further research going on risk modeling. Our group have done some work with the Dutch group using the UK HES data around orthopedic surgery, for instance, to produce a kind of risk assessment model, which can be converted into an app, which means that, you know, a substantial group of patients probably will benefit from less prophylaxis, and a smaller group might need escalated prophylaxis in terms of both dose and duration. So, there's, as I'm sure you're aware, an NIHR call at the moment for looking at lower limb immobilization, which has always been a controversial area, you know, with prophylaxis rates around the country of anything between about 10% and 40% in that group. So to try and identify the best approach at both risk assessing and you know, what prophylaxis they should receive. So there's also a couple of questions. Clearly, thrombosis has been a major complication of COVID pneumonia, particularly. Do you want to comment on the data from the NHS?
Well, I think what we know about COVID is that it has rendered people hypercoagulable, and there's been a high risk of a variety of different types of thrombosis and inflammation, vascular inflammation, for example. You know, very early on, we established that some people were seeing pulmonary venous inflammation, which potentially left them at risk of clots, but also we saw the sort of impact of that on palpitations, and ostensibly it's arguable that some of the sort of cardiac effects were related to inflammation around the conducting fibers and so on. I mean, there's a lot we still don't know about COVID, but there's been a huge amount of information to try and work through at the same time. And then I guess you're left with this whole issue of, over and above the standard risk assessment for patients being admitted, we do not have a COVID related risk assessment that has that does the patient have COVID box, and therefore they are at high risk, and therefore we should do something different. And maybe that's another area for development as we continue to deal with this disease, as we will for some time, of there seems to be a direct impact of COVID on your risk of thrombosis. Therefore, should that be something that we consider as a separate risk factor that encourages us to use thromboprophylaxis for another group of patients that would be in that respiratory medical group?
Yeah, so thank you for that, Aidan. I mean, it has been an extraordinary couple of years, and I think even just in the rate of change of the various guidances and differences of opinion as to what is the best thing to do, I think there's no doubt that with the alpha and delta strains of the virus, and with the first and second waves, particularly venous thromboembolism was very, very prominent part of it. But I think with time we are seeing less. That might in part be due to the Omicron variant not causing as much inflammation and immunothrombosis, in part also due to all the rest of the management of COVID has got better, whether it's simple thing like the hydration and the dexamethasone, or the antivirals and the anti-inflammatory and antibody therapies that have become available. I mean, we're seeing much less of it, but I think it engendered quite a lot of controversy as to, you know, what the dosing of the anticoagulation should be, and whether patients in the community merited prophylaxis either prior to admission to hospital or after discharge from hospital. I think a lot of people chose to sit tight, and I think probably now, you know, I think probably the optimal approach to thromboprophylaxis would be to give a standard dose, whether patients are on the ward or in critical care. But I think it's been, you know, there's been a lot of learning, and then there was that quite a difficult phase nearly a year ago when we became aware of the vaccine-induced thrombosis, thrombocytopenia syndrome with one of the vaccines. And again, since we have limited the use in younger patients, I mean, we've not seen a case in this country, thankfully. So I think it's been a period of, you know, extraordinary change and development and guidelines, and I think people have struggled to keep up with them. But I think we are back now where it's business as usual. And, you know, whether COVID, certainly a year ago, COVID in itself was an indication for in-hospital thromboprophylaxis if you were admitted with COVID. Good. So I think, let me just have a quick look at the questions. Yes, someone, oh yeah, John Luckett, one of our senior hematologists, is inquiring if anti-inflammatory antibody drug use has led to a reduction in VTE in COVID patients. I mean, that evidence has not been published yet, but certainly being in a center that has looked after about 10,000 COVID patients, I mean, we are not seeing as much VTE this time around, and certainly with Omicron, but no doubt there'll be publications. Another important area and question that comes to mind is certainly with the COVID, I think there was lots of data around the kinds of groups of patients that got affected, whether it was the older patients or patients in the minorities, and patients with comorbidities. Have you looked at that data for hospital-associated VTE? In your data set, for example?
In our data set, no. I mean, we've been looking more broadly at inequalities of harm overall rather than specifically at this subset so far. So one of the things we've been doing following COVID is we had a hypothesis that harm is unequally experienced as well as, so we've seen COVID being unequally experienced, and we were interested in whether harm overall is unequally experienced, and that is indeed the case. In fact, we just published an article in BMJ on the subject of understanding, firstly, that harm is experienced, any harm, including VTE, is experienced unequally. The factors in that are not surprising to anyone, but are important, and we've looked at them, and I think we came up with 7 themes for why, which would include communication and access to care and the sort of usual issues, and are now moving into the sort of how do we address from a generic point of view, whilst we might want to target VTE, how do we deal with the generic issue of harm being unequally experienced and try and reduce that level of inequality by working with the disadvantaged groups to empower them in a way that other groups are to try and avoid harm.
There is some data from the US, for example, that indicated that more deprived groups were less likely, for example, to get appropriate prophylaxis. And certainly there was a popular misconception about 10, 15 years ago that venous thromboembolism occurred predominantly in white populations because Black populations did not have the European thrombophilias like factor V Leiden. But I think our own group from Southeast London published several papers over a decade ago, which showed that VTE is equally, if not more common and more severe, in fact, in the Black population. So, but some of the current data coming out of the US indicates that those groups are still disadvantaged when it comes to optimal VTE prevention and care. So, yeah, it would be, I think, of interest to keep an eye on the national data as well. So, okay, I think we are approaching the hour mark. So do you want to, I mean, we are very, very grateful to Aidan for making the time to come and join us as the keynote speaker, kicking off this very, very interesting National Thrombosis Week program. But can we have some last words from you as to, where you see the National VTE Prevention program and initiatives going from here?
So I think, when I spoke to you before, I said this was an area we're going to focus on. I'm speaking to you now saying that the data we've found is fascinating and shows massive capacity to do more and do things differently, and it's timely to do that. We've had conversations with NICE recently about this, and they're keen to look at this again. We're having conversations with NIHR about this, and they're keen to support this. I think there's great opportunity, and what I'd like to be doing is coming back to you at some point, talking about what we've found and what we're doing about it and how that's making a difference. And I'd like to be coming back to you at some point in the future with that 12,000 and especially the 4,000, but also the 12,000 starting to come down.
Thanks. Oh, thank you. I'm delighted, as is Joe. I'm sure that NHS Patient Safety remains absolutely committed to VTE prevention and reducing this very significant burden of hospital-associated thrombosis, which I think despite all the best efforts and business as usual, more work is required, I think, to optimize VTE prevention and care. From the data that you presented and also from the kind of recent curve thrombosis survey report. So thanks again, Aidan, and thank you. We've had, I think, over 230 participants this morning, and this will be, the recording will be posted on the Thrombosis UK site for others to access as well, because I think England has been a real exemplar in setting up a systematic approach, and I think it's important for us to share this learning and the next steps as well.